what drugs might be useful for that specific tumor. And then there are other things, what additional factors do we know about this patient's tumor? Are we concerned about? There are some tumors that don't read the textbook. Somebody has a diagnosis, their tumor should have particular biology, and it really has some different biology. And again, that's where understanding the molecular features are very important. And we do run across some tumors that we just can't really put into the standard boxes. We can't classify them into the standard diagnoses. So very briefly, I'm having trouble advancing my slides. Hang on a second here. There we go. I'm just going to go over kind of the major classes. And again, I think David Lewis talked about this in high-grade gliomas and low-grade gliomas here on this slide, is we have oligodendrogliomas, which are really defined by two key molecular alterations, mutation in its gene called IDH, and this alteration in chromosomes called 1p19q co-deletion. And the treatment there is either radiation and PCV or radiation temozolomide typically at diagnosis. We have astrocytomas, including grade 4 astrocytomas, and those are defined by the IDH mutation. They don't have this chromosome 1p19q loss, and then they have some other alterations. And then we have this kind of large category of tumors that are these IDH wild-type tumors of various grades, including IDH wild-type glioblastoma. And as we'll talk about it in more detail, most of those tumors have specific alterations, the ones I list here, EGFR, TERT, chromosome 7, gain 10 loss. But particularly in younger patients, this is where the advanced molecular testing can be most important, because this is where we really see some of the most targetable alterations like BRAF alterations, NTRK alterations, FGFR. And again, these are mutations or fusions of these various genes at the DNA level. Most of these patients we treat with radiation and temozolomide, but there are some exceptions. And then there's another type of tumor we're not going to really talk about called diffuse midline glioma, with H3K27 mutation. So this is kind of the high-level view of how I view the different classes of gliomas when a patient comes in to see me. I want to talk very briefly about a couple updates for diagnostic classification. So I just mentioned that in the past, glioblastoma and with grade 4 astrocytomas were defined by histologic features. Those were these things called microvascular proliferation and necrosis. But now we can diagnose them by molecular findings. Again, the specific ones being these EGFR amplification, chromosome 7 gain, chromosome 10 loss, or this TERT promoter mutation. And as of the current WHO criteria for a diagnosis, if a tumor is IDH wild type, is an astrocytoma, and has one of those three alterations, you can diagnose that as a glioblastoma. And so that has really improved diagnosis and, we hope, personalization of therapy for those tumors that previously kind of got mixed in with a number of other types of tumors. So in terms of the updated diagnosis, again, I mentioned that the molecular alterations aren't variable across the tumor for the most part, so we can take a very small piece of tumor and get a very definite diagnosis. Where the targeted therapies and the molecular diagnosis are most important, I would say, is in this IDH wild type group of low and high grade gliomas, including glioblastoma. And a lot of these targeted alteration or targetable alterations happen in the younger patients. So let's kind of talk about some examples. So I want to just start with a series of patients. These were all younger patients that I've treated, came in with MRIs looking like this. And we won't kind of talk about all the details of the MRI, but these are flare sequences. So what we're looking at in white here is water. And each of these tumors, this one here, and this one here, show up as abnormalities. And these tumors did not enhance. So they didn't have high-grade imaging features. So from imaging and initial pathology, they all look very similar. They were low-grade astrocytomas. But when we start doing the molecular alterations and doing the tumor sequencing, we see some big differences. So this tumor had an IDH mutation, was 1p19q intact, like we talked about, had no CDKN2 loss. We'll talk about this in a second. So this tumor was a grade 2 astrocytoma, IDH mutant. However, this tumor was also IDH wild type astrocytoma, but had that EGFR amplification. So as we talked about, this is actually a glioblastoma, even though it doesn't look like one on the scan. And this one is a rare type of tumor. It was IDH wild type, did not have the glioblastoma alterations. It has a mutation in this gene called BRAF, which we'll talk about in more detail. And it's this rare entity called plenty. So even though the tumors looked similar on imaging, the initial pathology was similar, the molecular alterations really allow us to define these as very different tumors, and they have different treatments and different outcomes. So this patient had resection, initially wasn't treated with anything, then there was a little bit of recurrence and got treated with radiation and temozolomide, and has done very well over a number of years with no recurrence. This tumor had a resection, and patient received radiation and temozolomide because of the diagnosis of glioblastoma. And unfortunately, this behaved like a typical glioblastoma with a recurrence about a year or so later, and a big recurrence here in that left frontal lobe. And this tumor, because of the molecular features, we expect to behave very well. So this patient had surgery and no other treatment, and again, is doing very well multiple years later. So this is where, in my view, these molecular findings are most important for defining the diagnosis, seeing if you have a target that you can treat based on the specific alterations of the tumor, and using that to help personalize therapy. So there is a personalization of therapy we use of standard chemotherapy, temozolomide, and that is this marker called MGMT promoter methylation in glioblastoma. And this is the original paper. And I just want to kind of give an example of how we evaluate the effectiveness of therapy in patients. This is what's called a Kaplan-Meier curve. And on the x-axis is time. On the y-axis is percent of patients. And usually what we're measuring is percent of patients without some event, either progression of tumor or death. And so what we want to see with an effective therapy is a straight line where no patients are experiencing progression of tumor. So the farther up and to the right the curve is, the better the therapy is. The faster the curve is dropping, the earlier patients are having disease events. And so here you can see that tumors that have that, in glioblastoma tumors that have that MGMT promoter methylation, those tumors do better. Those patients do better over time than the unmethylated tumors. And here, what we're showing is that the patients that do the best are the patients where the tumor has the MGMT promoter methylation and they receive the temozolomide chemotherapy. So there's another target that we have thought for many years is a potentially really good target in glioblastoma, and that is that EGFR amplification, which is now a diagnostic criteria for glioblastoma. About half of glioblastomas have EGFR amplification, and about half of those, or 25% of the total, have a mutation in EGFR called EGFRB3. And so this looked like it was a really important driver alteration in glioblastoma, like it was causing formation of glioblastoma in about 50% of cases, and should be a very good target. There are EGFR alterations in other cancers like lung cancer where the therapies have been very effective. Unfortunately, there seems to be something different about glioblastoma. Either the EGFR alteration isn't as important in the biology, or the drugs just aren't getting into the brain very well. So here's just a list of all the trials over many years for EGFR inhibitors, drugs that target EGFR, that really failed to show a significant benefit. And there are multiple reasons why this may be. As I mentioned, maybe it's the wrong target. Maybe it's just not that strong a target in glioblastoma, and we shouldn't keep trying to target it. But there's a lot of concern that maybe it's just that these drugs aren't penetrating the brain and the blood-brain barrier very well. Maybe they're hitting the target, but not really inhibiting the pathway well enough. Maybe when you hit that pathway, the cancers are smart, and maybe glioblastoma upregulates other pathways to compensate. And maybe EGFR is important, but it's only important in a subset of cells, and then there are other alterations in other cells. And all of these are possible. And there's a new generation of EGFR inhibitors, probably the fourth or fifth generation now, that penetrate the brain better and are being actively investigated in early clinical trials for glioblastoma. So I still think this is a promising target, and maybe better drugs will improve the outcomes. So here's a summary from a few years ago of the targets in all cancers that are, I would consider, highly targetable. And there are a subset of these that we see in glioblastoma and high-grade astrocytomas. Unfortunately, it's a relatively small percentage of at least glioblastomas, but a higher percentage of pediatric tumors. And some of those alterations that are most common are IDH mutation. And again, this is in the grade 4 astrocytomas, IDH mutant, and we'll talk a little bit about targeting IDH. BRAF alterations, which in my experience has been one of the most effective targets, and we'll give some examples. FGFR alterations, both mutations and fusions. And there's some examples that maybe that's a good target in a very small percentage of glioblastoma. And you can just see there I've highlighted the different alterations, the different drugs, and the different cancers. And those cancers are where the drugs are FDA approved. So I just want to show you an example in a different cancer of what a highly effective targeted therapy looks like. So this is a famous picture from the New England Journal, the first targeted therapy that was developed for melanoma that targets that BRAF V600E mutation I mentioned. And here you can see on the left, before treatment, this is a patient with metastatic melanoma, and all of these little dark spots on a PET scan are metastases of the melanoma to multiple organs, to the bones, to the skin. Terrible situation. And here's the patient on day 15 of treatment with this drug that targets that mutation, that basically inhibits the mutant enzyme. And you can see dramatic improvement. Now, unfortunately, I see there's a question about MGMT. I'll come back to that at the end in the question session. We're going to leave 15 minutes. Again, I apologize. I can't see the questions in real time because they're on a different screen here, but I'll come back to that. So here's after therapy. Now, unfortunately, tumors, again, cancers are smart. Even when there's an effective therapy like this, cancers tend to find a way around it after some period of time, sometimes months, sometimes years. But this is really what we're hoping we can find for glioblastoma. And again, there are tumors, types of glioblastoma and other gliomas that have a BRAF mutation. Again, whether it's the blood-brain barrier and the drug not getting in as well, but here are the gliomas and here are the other cancers, and this is what's called a waterfall plot. So the bars show the increase or decrease in the size of the tumor after treatment. And you can see for lung cancer, for colorectal cancer, a fairly high percentage of tumors that are showing shrinkage or stabilization. In gliomas, a little bit more mixed. Definitely some tumors that have a BRAF mutation that were still growing significantly after it. So the lessons are, you can have a good target, you can have a good drug, but that doesn't necessarily equate to highly effective therapy, at least in the brain. You need a drug that's good in the brain, and that marker has to be have the same importance in the brain tumors. And these are just the challenges we have to face about poor blood-brain barrier penetration, understanding the biology. But we do often borrow these targeted therapies from other cancers where they've been highly effective. So here's an example. This, I'd say was a great success in a situation where things looked pretty bleak initially. So this is a young male, new onset seizure, has a scan like this. So this is enhancement. So this is, what looks like an aggressive tumor in the left frontal lobe, has a resection, and the pathology is glioblastoma IDH wild type. Started radiation and temozolomide, and partway through the radiation started having horrible headaches, neck pain, nausea, vomiting, suggested the tumor was spreading in the spinal fluid around the brain and the spinal cord, but actually the initial MRIs did not show any changes. So it took a little while for us to make a definitive diagnosis, but here you can see an MRI during radiation where you can see some enhancement along the base of the brain and in the cerebellum and along the spinal cord in the neck here, the sign of tumor expanding and spreading through the spinal fluid, a very aggressive feature. And this is during radiation. So this means this tumor is very resistant to radiation and temozolomide. So when we did the sequencing of the tumor, we found it has this BRAF V600E mutation. We actually did a methylation profiling, which came back saying the tumor should be better called pleomorphic xanthostrocytoma than glioblastoma. And this kind of highlights that there's some overlapping variants where, depending on which part of the diagnostic information you look at, you could call it glioblastoma, pleomorphic xanthostrocytoma, and there's several tumors like this in the glioblastoma family of tumors. People are interested, we can talk about this kind of controversy about what you call it. In this situation, I'm less worried about what we call it and what the treatment is. We actually documented that the tumors in the spinal fluid had that mutation. And so we started targeted therapy with 2 drugs that target that V600E mutation, dabrafenib and trametinib. And this is the MRI 1 month later, complete resolution of the evidence of tumor around the base of the brain and in the spinal cord. Patient got dramatically better within days of starting the therapy and has actually been on this treatment without any evidence of progression a year and a half later. And again, this is in a patient who was failing radiation and chemotherapy within a few weeks. And so this is what I consider a highly effective therapy. So somebody said, if EGFR mutation and mutation is put on a drug targeting the mutant EGFR, how often is there a response? In other words, does the tumor always respond to the targeted therapy 100%, or is there probability there won't be a response? No, yeah, this is the problem. So what I just showed you is a very good response in a BRAF mutation with BRAF targeted therapy. In EGFR alterations in lung cancer, you see dramatic responses like this, but it's a different EGFR alteration. In brain tumors, there are people who've reported responses to EGFR inhibitors, kind of isolated case reports, but on the whole, in the larger trials, the responses have been very disappointing. Like very few tumors that show shrinkage, does not seem to delay growth of tumor versus standard therapies. So right now, there are no EGFR inhibitors that are, I would say, used on a routine basis for treating glioblastoma. And here I just want to highlight, kind of again, some of the more targetable alterations. That EGFR is the most common, but right now not very targetable with our current drugs. FGFR alterations, MET alterations, ROS1, and BRAF. In gliomas, and you can kind of see the frequency of these alterations by the size of the dots. So again, EGFR is most common, but the therapies aren't very effective. These other are much less common. And even here, most of these tumors are going to be in the younger patients. Going to be relatively few GBMs in patients over, say, 60 that have these alterations, except maybe FGFR. That one we do see in some of the older patients. And this is just an example, again, a younger patient with a MET fusion where you can see a dramatic response, dramatic shrinkage of the tumor. But again, a very rare case. Typically don't see the MET fusions in adults, although we are opening a trial for MET drugs, for the very rare patient we see with these fusions. So the estimate for potentially druggable fusions in GBM, and again, this is including some of the pediatric glioblastomas, is only about 4%. In older adult glioblastoma, it's probably less than that. So got about 10 minutes left, and then we'll do questions. So I just want to kind of go over some specific examples of some targets and drugs and kind of how we're using them now and how we hope to use them in the future. So in grade 4 astrocytomas, the kind of dominant mutation is the IDH mutation. This IDH mutation is what we call a neomorphic mutation. So IDH is an enzyme. It takes certain inputs, acts on them, and has a normal output from the enzyme, which is this compound called alpha-ketoglutarate. When it's mutated, instead what it produces is this compound called 2-HG, which has a number of effects. And this is what we're trying to target with drugs. And so again, what happens is we have a mutation, you get a crystal structure of the mutant enzyme compared to the normal enzyme without the mutation, and very smart medicinal chemists figure out how to make a drug that fits in that active pocket of the enzyme with the mutation, but not the normal protein. And so you're specifically targeting that mutant protein. And we know from a lot of work, including Nobel Prize winning work, that the IDH mutation has many different effects in tumor cells, and it's seen in gliomas as well as a number of other cancers. It produces this metabolite called 2-HG that results in a number of things, something called pseudohypoxia. So the cell's acting like the oxygen level is low, even if it isn't. You get this increased DNA methylation, which alters how the cell expresses various proteins. And it also alters metabolism and DNA repair. And we'll talk a little bit about the DNA repair in a second. And there's other things that are going on as well. These are just kind of the highlights. So as I mentioned, smart medicinal chemists see a mutation. They see this biology that's resulting from it in the tumor. And so they make drugs that target that. And this is I would say an elegant study by Ingo Mellinghoff and others at Sloan Kettering and UCLA, testing two drugs, ivosidenib and vorasidenib, that target the IDH mutation. And here what they're doing is giving the drug to patients before surgery, then taking the tumor out at the time of surgery that's been exposed to the drug and comparing it against tumors that have gone to surgery and didn't get exposed to the drug. So they're really looking for specific changes in the tumor as a result of the drug. And what they showed is that with drug, you see decreased 2-HG levels, which is really important. That's what we want to see. And the lower the 2-HG level, it seemed like the more the less the cells were proliferating, the slower they were growing. So this looks promising, but there is a problem, at least for the higher grade 4 astrocytomas. And that is that these drugs did not seem to work in the enhancing higher grade tumors. They seem to work better in the lower grade tumors. And so that's where they're really being used, but not so much in the higher grade tumors. So I mentioned this CDKN2 alteration earlier. This is important because that's the molecular alteration that we use to really differentiate low-grade IDH mutant grade 2 and 3 astrocytomas from the grade 4. And CDKN2 is a potential target. So there are now companies that multiple companies make drugs for CDKN2. They've been successful in breast cancer. So far the existing drugs have not been effective in grade 4 astrocytomas or glioblastomas. But again, there's a new generation of drugs coming out. We just had a phase 1 study for a CDKN2 inhibitor. There was a first in human study. So glioblastomas and grade 4 astrocytomas were the first tumors that drug was being tested in. But I guess I mentioned, unfortunately, the IDH inhibitors are not effective in grade 4 astrocytomas, but we're hoping perhaps maybe IDH inhibitors combined with a CDKN2 inhibitor might be effective in these tumors. But that remains to be demonstrated. Again, just an example, IDH mutation alters metabolism. Here's a paper from Dan Cahill, and you can see that the IDH mutant cell lines, now this is in a dish, not in a person, are in color here, and the IDH wild type are not. And you can see that in the IDH mutant cells, this compound that blocks this NAMT pathway was dramatically effective in killing the tumor cells. Again, in a dish, remains to be proven in a person. So I mentioned that the IDH mutant tumors have some specific alterations in DNA repair. And one of these relates to this homologous recombination pathway. Won't go into details, but cancer cells have a way of repairing the DNA. A lot of the standard therapies we use, like radiation and chemotherapy, temozolomide, basically try and inhibit the cancer cell's ability to duplicate the DNA and divide into two cells. And so if you can, but the cancer cell responds to those treatments by repairing the damage done by the radiation and the chemotherapy. So if you can block some of those pathways that the cancer cell is using to repair the DNA, perhaps you stop the tumor cell from dividing and it dies. And so one of these pathways of repair that seems very important in IDH mutant tumors is this PARP inhibitor. And there's several papers in the literature that suggest that PARP inhibitors may be a good therapy for these IDH mutant tumors. This is being tested in a number of clinical trials. Again, not proven yet, but good biologic hypothesis that's being evaluated. I'll just mention, that in complicated tumors like glioblastoma, where there are many genomic alterations, many mutations, perhaps we can't target a single one. Maybe we have to find multiple ones, and it's very hard to just look at that list and figure it out. But there are various approaches being used for, high modality computing and deep learning. This is just an example from antibiotic discovery, trying to target resistant bacteria, but the same idea can be applied to tumors. And this is an idea of using training an AI system to look at different aspects of the tumor biology and look at existing drugs and try and match which drug would be best for that type of tumor. So, I'm optimistic that these things will be useful in the future. And I just want to end with the idea of personalized immunotherapy. So, immunotherapy has been very successful in many cancers, the idea that you activate the person's own immune system against the cancer. And here, the idea is that, again, cancers are smart. Cancers express things on their surface to prevent the normal immune system from recognizing it. So when an immune cell hits a cancer cell, it just recognizes it as part of the normal body and moves on. But immune cells recognize abnormal proteins on the surface. So one idea is the more mutations a cancer has, the more abnormal proteins it has, and the higher the chance the immune system can recognize it as abnormal. So that leads to this idea that in tumors with higher mutation rates, you can add something that blocks that inhibitory signal and hopefully allows the immune system to recognize all these abnormal proteins, all these multiple mutations, and activate against the cancer. And this has been highly effective in some tumors that have high mutational burden, like melanoma and lung cancer. And again, for brain tumors, things are more challenging, perhaps because of the blood-brain barrier and something called immune privilege in the brain. But we're trying to work on approaches to combine these things, high mutational burden and things that activate the immune system. So again, very promising. And here's just some examples of patients. So this is a grade 4 IDH mutant tumor, and this is a glioblastoma, patients with DNA repair defects, and you can see the large numbers of mutation. Normally we'll see 2 or 3 or 4. These patients have many. And I think one of the tricks is which patients do we try and use immune therapy on? And so this is an example, again, a pediatric example of a patient with a genetic alteration in their DNA repair, got treated with one of these checkpoint inhibitors that activates the immune system with a good response. Again, tougher in adult glioblastoma, but perhaps we have a few examples of where this has been successful. And there's a little bit of a controversy about which tumors we should target with these drugs that activate the immune system. So this is a paper from the Dana-Farber group that says you have to have a high mutational burden plus another alteration called microsatellite instability. There are other papers, this is from the Toronto group, that say maybe you don't need as high a level of microsatellite instability to get these drugs to work. And then this is a paper from the Duke group that kind of says the opposite, that it's actually the low mutational burden tumors that respond best to the immunotherapy. So this is a challenge. We're in the process of working out which of these tumors we should really use the immunotherapies in. And I just want to mention one other checkpoint here. There's a type of cell in the body called a macrophage, which is kind of the cell that eats other cells. Phagocytoses the other cells. And there's a molecule called CD47 that acts as the don't eat me signal. So again, cancer cells are smart. They express this molecule. When the macrophages hit that cell, they don't eat the cancer cell because they think it's part of the normal body. And there's a drug that's out there. It's in trial right now called magrolimab. It's an anti-CD47 antibody that blocks that don't eat me signal and hopefully allows the macrophages to eat the tumors, eat the cancer cell. So you have the abnormal cell, you block that don't eat me signal, and then hopefully that activates the macrophage and it eats the cancer cell. And so we do have a study open, about to open in adults and pediatric gliomas and GBMs. It's here, it's at Primary Children's here at University of Utah and at UCSF. It'll be the first test in brain tumors of this approach to trying to activate the immune system. And then there are a number of other, targets that are in development, many groups working on therapies. We talked a little about CDKN2 loss. You can see a list of other alterations, that are actively in development. And there are many others. This is just a small amount. And then there are other approaches like modified viruses, other immune checkpoint inhibitors like CD47, and then vaccines, either general vaccines for glioblastoma or grade 4 astrocytoma, or tumor-specific vaccines that are made from the tumor or made specifically based on the tumor biology. And again, these are all in active investigation. So just to summarize, correct diagnosis is crucial for personalization of therapy. And that's where I start with every patient. What do we know about this tumor? Does that lead us to any additional therapies? The molecular diagnostics and these new integrated diagnoses in WHO 2021 really highlight at least a subset of the potential options for targeted or immunotherapy. There are really a limited number of these alterations that have proven to be the most promising ones in glioblastoma and grade 4 astrocytoma. But I'd say there's another tier of ones that look promising, and there's a lot of active investigation. And again, the ongoing trials and the work in the lab is really aimed at figuring out what's the best target or combination of targets and drugs to use.